Welcome back. MedGirl brings you another dose of trusted medical insights. Today we're going to discuss about pleural effusion. Come, let's check it out. So, what is pleural effusion? It is the accumulation of fluid in the pleural space. This blue area in the diagram shows fluid collection in the pleural cavity. There are two types of pleural fluid. One is transudate and the other is exudate fluids. Now, what is a pleural space? A thin fluid-filled space between two layers of tissue surrounding the lung. Outer layer lining the chest wall and diaphragm is the parietal pleura. Inner layer covering the surface of lung directly is the visceral pleura. When extra fluid accumulates in this space, it is called pleural effusion, which leads to lung compression, resulting in shortness of breath. What are the symptoms of pleural effusion? Shortness of breath, pleuritic chest pain, dry cough, and difficulty in breathing when lying flat. Now, let's take a look at the signs of pleural effusion. Patient would appear dyspneic, therefore you can see increase in respiratory rate. You can see reduced chest movement on the affected side. Large effusions can also cause tracheal shift to the opposite side. You can see patients use the accessory muscles for respiration, such as sternocleidomastoid and the intercostal muscles. On percussion, stony dullness can be heard. On auscultation, you can hear bronchial breathing, absence of breath sound on the affected side, and also pleural friction rub can be appreciated. So what are the investigations we can do for pleural effusion? As for blood tests, we can do complete blood count. It may show increased WBC levels. This indicates infection, example in cases of empyema. CRP and ESR, this is elevated in cases of infection, inflammation or malignancy. Serum protein and LDH, used in Light's criteria to differentiate transudate from exudate. We can also do serum glucose level. It's found to be low in cases of tuberculosis, malignancy, rheumatoid effusion. Serum creatinine and urea, done to assess renal function and rule out uremic effusions. And serum amylase, increased in cases of pancreatic pleural effusion or esophageal rupture. As for imaging tests we can do, erect chest X-ray and PA view. You can find blunting of costophrenic angle due to collection of fluid in the lung bases, and this ascends towards the axilla. A meniscus sign can be seen, which is the curved upper border of fluid. Another imaging we can do is an ultrasound scan of the chest. It helps to detect even small amounts of fluid collection accurately. A clear hypoechoic space is suggestive of transudate, and moving floating densities on scan is suggestive of exudative fluid. Also, it helps to guide thoracocentesis safely. CT scan of chest is indicated in cases where malignancy is suspected, to look for masses. Ultrasound-guided pleural fluid aspiration, also known as thoracocentesis, a diagnostic procedure where pleural fluid is removed and sent for sampling. In some cases, by looking at colour and texture of fluid, we can suggest a diagnosis. Example, blood, indicative of malignancy, pulmonary infarctions, but it also could mean a traumatic tap. When we analyse the fluid further in labs, we look at pH. A low pH suggests causes like rheumatoid arthritis, esophageal rupture. Microbiology analysis using gram staining, acid-fast bacilli smear and culture can suggest us information on infective causes like parapneumonic effusion and tuberculosis causing effusion. Also, other biochemical parameters like cell count, glucose, LDH, protein, amylase, cholesterol and triglycerides also help us classify fluid into exudate or transudate. We use the pleural fluid aspirate sample to differentiate between transudate and exudate. We use the Light's criteria for classification. The aspirate is exudative if any of the following are true. Pleural fluid protein to serum protein ratio is more than 0.5. Pleural fluid LDH to serum LDH ratio is more than 0.6. Pleural fluid LDH ratio more to third the upper limit of normal, serum LDH. Pleural biopsy, often guided by ultrasound or CT, helps obtain tissue for both microbiological testing, such as identifying infections like tuberculosis, and pathological analysis, especially to diagnose malignancies. What is the difference between transudate and exudate fluid? Transudative fluid is because of the imbalance in the hydrostatic pressure and osmotic pressure. Either an increased hydrostatic pressure or decreased osmotic pressure causing fluid to pass into the pleural space. Exudative pleural fluid forms due to inflammation or damage to the pleura or nearby lung tissue. The tiny blood vessels, microvasculature, become more permeable. This allows fluid, proteins, and even cells to leak out into the pleural space. A few examples of transudative fluid are heart failure, liver cirrhosis, and nephrotic syndrome. As for exudative fluid, it can be seen in malignant diseases, autoimmune conditions like rheumatoid arthritis and SLE. Also, infections can cause exudative fluid. Example, tuberculosis or pneumonia. And also in subdiaphragmatic conditions like acute pancreatitis and subphrenic abscess. Management of pleural effusion. Sit the patient in upright position and give oxygen supplementation for relief from shortness of breath. Monitor vitals: blood pressure, pulse rate, respiratory rate, temperature, and oxygen saturation. We do thoracocentesis as a therapeutic measure where a needle or catheter is inserted into the pleural space guided by ultrasound to remove fluid or air. This will help relieve the patient from breathlessness. It is also done as a diagnostic measure to analyse the fluid which I discussed during investigations. By the way, when simple thoracocentesis isn't enough, for example in large volume effusions or malignant effusion, we can also do chest tube drainage. This involves insertion of a tube into the pleural space to continuously drain air, blood, pus or fluid. Some of the indications for this procedure are empyema, infected with pus, massive effusions, complicated parapneumonic effusion with a positive culture. Also, when there is reaccumulating effusion. Example, in cases of malignancy. It is also important to treat the underlying cause once we have resolved the breathlessness and stabilised the patient's vitals. For example, in cases of pneumonia, antibiotics can be given either oral or IV form. For heart failure, diuretics can be started to manage fluid overload. For tuberculosis, anti-TB drugs can be begun. Example, rifampicin, ethambutol. There are also instances where pleurodesis, a medical procedure, is used to permanently eliminate the pleural space by causing the visceral and parietal pleura to stick together, done in cases of recurrent pleural effusions. And that's a wrap on pleural effusion, folks. If you found this helpful, give it a like and drop a comment. I'd love to hear your thoughts. Don't forget to hit that subscribe button for more simple, straight-to-the-point medical videos. See you in the next one.